Bismillah ar-Rahman ar-Rahim. Our lecture today on the ischemic heart disease. Ischemic heart disease are a group of closely related syndromes caused by imbalance between the myocardial oxygen demands and the blood supply. It's account for 80% of cardiac death and nearly one-third of all the death in the USA. The most common cause of ischemic heart disease is atherosclerosis of the coronary arteries. That to say, there is narrowing or obstruction in the coronary vessels that result in the ischemia of the myocardium. So, commonly called coronary artery disease, is the same for the ischemic heart disease. The clinical syndromes of ischemic heart disease classified into the four main topics: angina pectoris, myocardial infarction, sudden cardiac death, chronic ischemic heart disease, and congestive heart failure. This is the main four syndrome that under the umbrella of ischemic heart disease. Start with angina pectoris. What's meaning by the angina pectoris? Angina pectoris is a clinical syndrome characterized by paroxysmal attacks of chest pain, usually situated retrosternally. This pain radiated to the pericardium, left shoulder, upper limbs, and other side, and so that is considered as the referred pain. That to say, the pain originated from the myocardium and radiated toward the other areas. There are three main types of angina pectoris of this clinical syndrome. The first, what we call classical or stable type of angina pectoris, stable type. This type of the angina pectoris is precipitated by exertion and emotion, and less by other form of increased myocardial oxygen demands, like tachycardia or hypertension, due to the fever, anxiety, and fear. So, this type of the angina pectoris is the classical type that are precipitated by exertion, relieved by rest and nitroglycerin, which are coronary vasodilator, and caused by critical coronary stenosis when about 75% of the caliber of the coronary vessels are obstructed or occluded. This type of the angina pectoris will be occur. The second type of the angina pectoris is the vasospastic. Vasospastic, there is no evidence of stenosis, but there is a spasm of the coronary vessels. Can occur at rest, not only by the exertion like that of classical type of angina pectoris, due to the coronary artery spasm, and less frequently related to the effort. Respond to the nitroglycerin, that to say, can be respond to the vasodilator therapy, and characterized by the ST segment elevation by the ECG. So, this type of angina pectoris caused by the coronary artery spasm. Usually, this spasm occurs over an area of atheromatous plaque. As we said previously, the atheromatous plaque or the atherosclerosis is the cornerstone for all the cardiovascular pathology. So that the spasm of the over the area of the atheromatous plaque, but completely normal vessels can be affected. That to say, not only over the atheromatous, but commonly over the atheromatous plaque, but even the normal vessels can be affected. Both the stable type and vasospastic type, or what we named principal angina, don't cause any significant myocardial change. Still, there is only ischemia, and accordingly there are no microscopical change in the heart. There is no evidence of any myocardium necrosis and some other pathology that be seen in the myocardium. There is no evidence of the pathology in the vasospastic and stable type of angina pectoris. The third type, which is the unstable angina pectoris, what we named pre-infarction angina. That to say, the type of angina that are precede the infarction. Unstable angina may progress to an infarction, so that named as pre-infarction angina, characterized by the pain that become more and more severe with the time and provoked by less and less effort or emotion. With the time, the pain will be more and more severe and precipitated and provoked by the less effort. This type of angina, characterized by episodes, tend to be more intense and longer lasting than the stable angina, more severe and take more time to occur. Nitroglycerin is required more dose and less effective. That to say, we need a larger dose of the drug, and in spite of larger dose will be less effective in this type of unstable angina. This type of angina carry a bad prognostic indication. As we said, it can be passed to the infarction and caused by the acute plaque lesion. What's meaning by the acute plaque lesion? As we mentioned previously, the thrombotic plaque are liable for the fissuring, ulceration, and even rupture, and this is considered as the predisposing factor for development of the complication of the thrombotic plaque. So, the acute plaque lesion means rupture of the plaque superimposed by the partial thrombosis, as atheroma rupture result in the intimal defect, which are covered with the thrombi, causing severe narrowing of the lumen, and also peripheral emboli result in the ischemia. So that with the rupture of the atheroma and formation of thrombosis, and there is evidence for the development of the thromboembolism as a result of the showering from the site of the coronary vessels. Unstable angina may be accompanied by the focal myocyte necrosis. In contrast to the other type of the angina, which are not associated with any pathology in the myocardium, this type of angina may accompanied by the focal foci of myocyte necrosis, which repaired by the foci of fibrosis. So that is very essential pathology regarding the differentiation with other type of the angina. This three type of the angina may later on develop or pass toward the myocardial infarction. So that stable angina, vasospastic angina, and unstable angina, all this can be passed later on with the time to the condition of what we named as the acute myocardial infarction. Myocardial infarction means an area of ischemic necrosis. That to say, anoxic necrosis of myocardial cells caused by the ischemia. Ischemia means lack of the blood perfusion. Acute myocardial infarction is the most common cause of death in the West, where about 1.5 million per year in the USA, and half millions death, large number of which will don't reach the hospital. The risk factor is the same for atherosclerosis. As we talked previously, atherosclerosis is the cornerstone for the cardiovascular pathology, with the same risk factor for development of atherosclerosis can result in the myocardial infarction. There are two types of myocardial infarction, either transmural. Transmural means the entire thickness of the wall of the myocardium are involved by the necrosis. So there's a full thickness infarction from the endocardium to the subpericardial fat. That to say, endocardium, myocardium, even reach to the epicardial fat, about 2.5 cm in the diameter, caused by severe atheroma with acute plaque change, leading to the complete occlusion. And as we talked previously, acute plaque lesion means there is a rupture of the atheroma, formation of thrombus, and occlusion of the vasculature. So that complete occlusion results in the transmural myocardial infarction. And the second type are subendocardial, when there is a limitation of the infarction in the lower inner third or half of the wall thickness, caused by the global ischemia. That to say, there is a hypoperfusion, global ischemia. There is hypoperfusion, like the due to atheroma, that are precipitated by the increased demand, like that's occur with the exercise. For example, with the exercise, there's increase in the demand, and so there's a global for the entire myocardium, not a focal like that of the transmural, under the influence of the occlusion, but it's hypoperfusion that's occur in the entire myocardium, that result in the limited thickness in the wall necrosis, including either the inner half or inner third. Regarding the morphology of myocardial infarction, the first are the size of the MI depending on the segment of coronary artery that are blocked and the state of collateral circulation. So that collateral circulation is essential for the supplement of the area with the blood vessels. Once occlusion occurs in the major artery supplement for the area, the perfusion depending on the collateral circulation. When the collateral is intact and safe, there is a limited ischemia will occur. But if the collateral circulation is impaired, the ischemia will be frank and global and will be result in the necrosis, what we named or as myocardial infarction. The second, the location of MI, depending on the site of the occlusion and type of coronary circulation, depending on the circulation of the blood in the left anterior descending coronary involvement that's occurring about 40 to 50%, this will result in the myocardial that involving the anterior and apical left ventricle and anterior two-thirds of the interventricular septum. When the right coronary artery that's occurring about 30 and 40% involvement by the occlusion, this will supplement result in the myocardial occur in the right ventricle, posterior wall, left ventricle, and posterior third of the interventricular septum in the right dominance, those with the right dominance hand. The left circumference artery that's occur about 20%. This result in the infarction that's occur in the lateral left ventricle, except the apex and posterior wall in the left dominance. So that the size depending on the collateral circulation and the size depending on the type of the coronary vessels that are involved. Regarding the morphological and the pathological changes that are seen in the myocardium during the infarction, depending on the time. In the first day of infarction, the myocardium will be pale on the gross examination with no histological change on microscopic examination, with the beginning of coagulative necrosis and the edema. This is in the first day when the infarctions occur or the occlusions occur in the blood vessels, coronary blood vessels. The myocardium will showing this feature in the first day. The second day showing that the coagulative myocardium necrosis occur with loss of the nuclei and striation and interstitial infiltration of the neutrophil. Third day showing fragmentation of the necrotic cells and the sum of the neutrophil that's seen. Fragmentation of the myocardium and the neutrophil in the third day. The fourth day showing the influx of the macrophage, which slowly replaced the neutrophil and removed the dead myocardial cells. With the time, at the end of the first week, there is ingrowth of angioblast, marks the beginning of the granulation tissue formation. That to say, the granulation tissue formation starts to be in the end of the first week, about 7th day. While the second week, the granulation tissue began to replacing the necrotic myocardium. That's occurred in the first week. At the second week, the replacement completely replacing the necrotic myocardial tissue by the granulation tissue. While the third week, the granulation tissue slowly transfer into the fibrous tissue. At the 6th week, a fibrous scar will form, and this will result in the dense collagenous scar. So that during this time, there's a change that are essential to oriented, because the essential to manage the patient and also in the forensic medicine regarding the time of the myocardial occurrence. What about the infarction modification after reperfusion? Sometime with the occlusion of the blood vessels that result in the myocardial infarction, this occlusion are opened either spontaneously or some of the drugs that result in the dissolving of the clot or causing vasodilatation of blood vessels. Finally, we end with the reperfusion of the area that are affected by the infarction. So, reperfusion sufficiently early within the 20 minutes after the ischemia may prevent any myocardial necrosis. That to say, when this step of reperfusion occur within 20 minutes after the ischemia, this reperfusion may prevent any myocardial necrosis. If the reperfusion will be later on, it might limit the size of infarction. If the reperfusion occurs too late, may result in the hemorrhage into the necrotic tissue. That to say, hemorrhage will occur in the necrotic tissue that are not prevented by this reperfusion because it's occurred too late. What the outcome of the myocardial infarction? Myocardial cell cannot regenerate, as you know. Thus, necrotic cells are replaced by the fibrous tissue, resulting in the fibrous scar that is mostly founded at the site of all the healed infarction. So that infarcted myocardium are replaced by the fibrous scar, and the patient may die before the infarction heals. That to say, at the autopsy during the forensic dissection of the myocardium, what we named as autopsy examination reveals that macroscopical and microscopical examination features of infarction at the various stage of the evolution and or healing that are previously we discussed. During the autopsy, the examination of the myocardium may see the various stage of the healing that's occur during the myocardial infarction. This is the stage of the granulation tissue, as we talk in the second, at the end of first week and beginning of the second week. The granulation tissue that composed of the proliferating capillaries and in addition to the inflammatory cells, instead of the area of the myocardium. This is the residual myocardium, and this is the area of infarction that are replaced by the granulation tissue that's occur in the second week. This granulation tissue later on replaced by the fibrous tissue forming the scar. Reperfusion may occur too late, that result in the bleeding in the area of ischemia of the heart, and this is a bleeding that's occur when the reperfusion occur too late, that are not prevent the myocardial necrosis. Later on, with the healing of the granulation tissue, the scar can be seen. We see here area of the scar that indicate the presence of the necrosis can be seen in the myocardium and replaced by the scar. What about the complication of the myocardial infarction? After the infarction, about 25 patients experience death, sudden death due to the fatal arrhythmias. Arrhythmias mean there's irregularity in the cardiac contractility between and imbalance between atrial and ventricular contractility. This named as arrhythmias. Some type of arrhythmias are fatal, that are not appropriate for the life, so that the most common complication of the myocardium, about 25%, will develop sudden death because of the fatal arrhythmias under the influence of defect in the neural system of the heart between the SI node and the various neural supplement of the heart. So that the main complication are the fatal arrhythmias that result in the death, sudden death in 25% of patients with MI. If the patient survive the acute event, that to say the patient will pass the acute events of MI and will still alive, 80 to 90% will develop complication. That's arrhythmias that are not fatal. Arrhythmias, that's irregularity in the contractility of the heart and imbalance between the contractility of atrium and the ventricle, and under the influence of the disorder in the neural system of the heart, including SI nodes and the various branches of the neural system. The other complications are the congestive heart failure that occur in about 60% when there is pump failure due to the weakness of the myocardium. Under the influence of the MI, the myocardium will be weak, and this will result in the congestive heart failure. Cardiogenic shock, that's occur 10% with infarction, about occur in the 40% of the left ventricular mass. This will result in the cardiogenic shock, especially when there's an extensive myocardial infarction that involves about 40% of the left ventricle. Papillary muscle infarction of the valve with or without rupture of the muscle, leading to the mitral valve dysfunction. Mural thrombosis mean thrombosis in the area adjacent to the wall of the heart, that showing the myocardial infarction because this part of the myocardium will be paralyzed and no contractility will occur, and this allows the thrombus formation which is named as the mural thrombosis with the thromboembolic phenomena that's occurring about 40%. Deep venous thrombosis and thromboembolic phenomena that can be seen also under the influence of the formation of the thrombus and the paralysis of the part of the myocardium, and this will development of the thromboembolic phenomena and stasis in the myocardium, stasis in the blood circulation that result in the deep venous thrombosis. Ventricular aneurysm, as the result of the myocardium, the weakness in the heart and development several weeks and months after the infarction at the site of large myocardial scar, because the myocardial scar will be weaker than that of the myocardium, and this area of weakness liable for the bulging under the influence of the contractility of the heart and abundance of the blood in the cardiac chamber, so that there is a weakness in the area in the bulging and formation of the ventricular aneurysm. Pericarditis, subpericardial necrosis in the area of myocardium will lead to the sterile inflammation. Sterile inflammation, there is no evidence of the bacteria. Only there is inflammation in the area of the epicardium and with the exudation of the fibrin. This is a picture for the myocardium with the held by the fibrosis. This is the area of myocardium that are exposed to the myocardium infarction and later on replaced by the fibrous tissue that are weaker than the myocardium hair, and this is fibrous tissue start to be bulging gradually until the end of the aneurysm that are liable for the rupture. So that this is a ventricular aneurysm, one of the complications of the myocardium that are liable to rupture and forming the ventricular aneurysm. Another topic of the ischemic heart disease are sudden cardiac death. So that there are 4 types: angina pectoris, myocardial infarction, and the sudden cardiac death. What's the sudden cardiac death? It's not related to the myocardium. It's an ischemic heart disease. Sudden cardiac death defined as unexpected death from the cardiac cause within 1 hour of the onset of the symptom. That to say, development of the symptom within 1 hour then pass to the death, and this is unexpected death from the cardiac cause. Majority are complications of ischemic heart disease. About 75 to the 95% have marked atheroma. That to say, the underlying influence of the atheroma can be seen. Typically, it develops over the ruptured soft atheroma, which named as the major complication and dangerous complication of atheroma is the ruptured atheroma that are passed to the death in the form of the sudden cardiac death. Other causes include marked aortic stenosis, abnormality of the conductive system, myocarditis, mitral valve prolapse, and cardiomyopathy. And all cause, the ultimate death are the fatal arrhythmias that result in the death within 1 hour of development of the symptom. Another topics are the hypertensive heart disease. Hypertensive means the underlying influence of the hypertension that affect on the heart causing disease. There are 2 minimal criteria for the diagnosis. The first, a history of hypertension to be underlying cause of the disease. The second is the left ventricular hypertrophy, because the hypertension, chronic hypertension, usually result in the progressive enlargement in the left ventricle in the absence of other cause of the left ventricular hypertrophy, a component for the hypertrophy. So that hypertension result in the left ventricular hypertrophy with absence of other cause of the hypertrophy. So the stimulus for the left ventricular hypertrophy is the chronic pressure overload due to the chronic hypertension. With hypertrophy of the left ventricle, sometimes we still have an adequate cardiac output in spite of hypertrophy, trying to maintain a good amount of the cardiac output. This named as compensated hypertensive heart disease. That to say, in spite of hypertrophy, but still there is a good amount of the cardiac output. Thickening of the muscle wall increase the demand for the oxygen, because this hypertrophy will result in the increased amount of the oxygen for the myocardium, and gradually this result in the decrease in the compliance of the heart, and all this result in the decompensated hypertensive heart disease, and eventually there is ventricular dilatation because of the reduction in the complex of the myocardium under the influence of the increased demand of the oxygen, and so that finally we end with the decompensated hypertensive heart disease and ventricular dilatation. So in the compensated hypertensive heart disease we have constrict hypertrophy, while in the decompensated we have dilatation. Both stage have heart weight increase the 500 grams. Regarding the histology, the large fibers with the large polygonal cells, later on interstitial fibrosis and thickening in the wall of the left ventricle may exceed 2 cm. With the time, the increase in the thickness of the left ventricular wall impart a stiffness that impair diastolic filling and result in the gradually in the heart failure. So the cause of death in the ischemic heart disease are congestive heart failure, as we said, increase the risk of the sudden cardiac death, mainly are fatal arrhythmias, and renal disease, stroke, or unrelated cause can be cause the death in those with the hypertensive heart disease. Therapy are the drug control leading to the regression of the hypertrophy. The last topic are what we name pulmonary hypertensive heart disease. As you know, there is a pulmonary circulation that are bind between the lung and the right side of the heart, in addition to the systemic circulation that are bind between the left side of the heart with the lung. So the right ventricular hypertrophy and dilatation can be seen secondary to the pulmonary hypertension. That's to say, hypertension in the pulmonary vessels will reverse systolic pressure on the right side of the heart, result in the right ventricular hypertrophy caused by the primary disorder of the lung parenchyma or pulmonary vasculature, both, whether the lung parenchyma or pulmonary vasculature, both resulting from the disorder that affect either structure or the function of the lung. So either the disease in the lung or in the pulmonary vessels or the chest movement or any disorder in the arterial vasoconstriction, all these cases may result in the pressure of the blood toward the right side of the heart that result in the acute or chronic pulmonary heart disease, hypertensive heart disease, what we name cor pulmonale. So that the acute cor pulmonale most commonly follow massive pulmonary embolism. That to say, massive sudden pulmonary embolism with the obstruction of more than 50% of pulmonary vascular beds that result in the acute pulmonary hypertension. And this acute pulmonary hypertension will reverse its effect on the right side of the heart, result in the acute cor pulmonale. While the chronic cor pulmonale occurs secondary to the prolonged pressure overload caused by the obstruction of the pulmonary vasculature or compression or obliteration of septal capillaries resulting from the emphysema, interstitial fibrosis, or primary pulmonary hypertension.